All right, this part of the lecture is usually where I spend the most time in class. This is going to be on blood products, blood transfusions, and blood transfusion reactions. Again, your ATI loves this stuff, okay? So let's make sure that we do it the due justice that it deserves, because administering blood is a pretty common thing that we do in the hospitals, but it can also be a really challenging thing if you're not prepared for this, okay? All right, so blood products, okay? So transfusions, okay? Transfusions, most of the time when we think about a transfusion, we usually think of packed red cells. But we can transfuse platelets, we can transfuse albumin, we can do fresh frozen plasma, we can do cryoprecipitates. And all of them are considered blood products, okay? So the transfusion procedure allows administration of a wide range of your blood products. So red blood cell transfusions are going to revive your oxygen-starved tissues, for example. Your leukocyte transfusions, we can do that. They can combat infections beyond the reach of antibiotics. And we have transfusion of clotting factors, plasma, and platelets that help patients with, hemophilia, for example, live virtually normal lives. But most of the time when we're talking about blood products, we're usually talking about red blood cells. So we have packed red blood cells, or PRBCs. And you have frozen red blood cells, which have to be thawed and then can be transfused into your patient. So a patient with severe anemia or acute bleeding that drug or nutritional therapy can't correct may require a transfusion of either whole blood or packed red cells. A whole blood transfusion replenishes both the volume and oxygen carrying capacity of the circulatory system by increasing the mass of red blood cells. In contrast, a transfusion of packed red blood cells, which is the most common type of transfusion, restores only the oxygen carrying capacity of the circulatory system because 80% of the plasma has been removed before transfusion. So packed red blood cells may also undergo a special washing procedure, which I'll talk about that's on the next slide. That actually removes the red blood cells and the platelets, which decreases the chance of a reaction in patients who were previously sensitized to transfusions. So actually, I'll just go ahead and go to the next slide. That's that washing that I have down there. Washing is something that you would do for an individual who's high risk for an infection. So usually the example I give for this is in pediatrics. I talk about like a neonate, for example, an individual or a baby who is in that first 28-day cycle, very, very high risk for an infection if they required a transfusion. So the lab could actually do what they call washing, which would remove the leukocytes from the blood so that your patient would have a much better chance of taking it very easily. Okay, so here's some of our transfusion safety tips. Okay, so it's really important that you become familiar with your facility's policies and procedures for administering blood products. I'm going to go through the majority of what we see, but keep in mind that states have different policies for their stuff, and it could vary from hospital to hospital. So you want to explain the procedure to the patient. Make sure that the patient's medical record has a written physician order and a signed consent. You have to have a signed consent to do a blood transfusion. You want to verify that the patient has an appropriate patent peripheral or central venous access site for administration. That means they need a large bore IV, okay? You can take that for what you mean. Most of the time for adult patients, we consider that an 18 gauge. You may not be able to get an 18 gauge in some of these elderly, frail patients. So at that point, maybe a 20 gauge would be appropriate. So we always say large bore IV. The bigger IV you can get in, the better, because the smaller the gauge that you have, there's a much higher risk that you're going to have hemolysis of the blood, which is not something that we want, which is where the red blood cells would break down. So you want a large patent IV in a peripheral site, or if you have a patient with a central venous access device, like a central line, you could actually use that as well. You want to assemble the necessary equipment. That includes a standard blood administration set with an appropriate filter. In the hospital, we call that Y-site tubing, okay? If needed, you want to flush the venous access device with normal saline. You only use normal saline. That is the only type of fluid that can be infused with blood components, okay? That's a really important one to know. You want to obtain the patient's baseline vital signs and collect the blood from the blood bank. If the blood isn't going to be transfused, it has to be returned to the blood bank within 30 minutes. So from the time you pick up the blood in the blood bank, you have to have it entered the patient's circulation, it has to begin transfusion within 30 minutes. If not, you have to return it. You want to inspect the blood product for any abnormal color, cloudiness, clots, any excess air, and you want to match the blood to the written order. You want to verify the patient's identity using a two-person verification process in the hospitals, okay? And again, it depends where you work. This should be 2 nurses, and the Nurse Practice Act is very, very vague about this, okay? I am telling you, it has to be an RN. That has to be the one that administers it. We prefer 2 RNs being the ones that are double checking to make sure that it's compatible, but it depends on your hospital. Okay, I've worked in some places where an LPN was considered acceptable to double check the blood. In Missouri, I was allowed to double check blood with a patient care tech, but I am telling you in Illinois, it is 2 nurses, okay? But remember, the RN has to be the one to transfuse the unit, okay? We don't start the infusion if you find any discrepancies, and if we do find any, you want to notify the blood bank immediately. So before the transfusion, we're going to check those patients' vital signs. You're going to monitor the patient carefully throughout the transfusion, and we keep in mind that the transfusion reactions are usually going to happen in the first 15 minutes of starting the transfusion. So because of that, the RN has to stay at the bedside for those first 15 minutes, okay? The RN is the one that has to do the initial assessment, so an RN has to be the one at the bedside monitoring the patient. The transfusion has to be in within 4 hours, okay? That doesn't mean it has to stay hanging the full 4 hours. It just means the entire product needs to be administered in 4 hours, okay? If the patient needs multiple units, you want to change the administration tubing after every unit to prevent infections if possible. If the patient develops an adverse reaction, the first thing we do is we stop the transfusion at once and we notify the physician according to the policy. Keep the vein open with normal saline, obtain vital signs, and begin your appropriate nursing interventions. Okay, and I'll talk about the transfusion reactions in just a second. All right, so transfusion complications. Okay, there's multiple different types of complications that you can see. But these are the main ones that your book will talk about. So the first one is a febrile reaction, okay? This happens because of some kind of bacterial component is occurring in here. The fever is usually within 2 hours of the transfusion. They may have chills, headaches. They may complain of palpitations, cough, tachycardia. The way that we fix this, again, we relieve symptoms with an antipyretic. So acetaminophen is usually what we utilize in the hospital. If the patient requires further transfusions, you may want to consider a process that removes the leukocytes. Okay, so we can talk to the lab about washing, like I said, we talked about that earlier, washing the packed red cells so that they don't have a febrile reaction. You can also pre-medicate the patient. If they have a history of febrile reactions, you may want to pre-medicate them with acetaminophen prior to the actual transfusion. We do this quite a bit, actually. There is an urticarial reaction. Urticarial reaction is just, urticaria means rash or an allergic reaction, usually an allergen in the blood, the donor blood can bring this on. So signs and symptoms of this, they'll have the urticaria or the hives, the rash. They may get a slight fever, they may have nausea, maybe even a little respiratory distress. So an urticarial reaction can go into a hemolytic, or I'm sorry, an anaphylactic reaction, okay? So you want to make sure that, you know, we're assessing the patient for any facial swelling, any laryngeal edema, just in case we are progressing into anaphylaxis. For urticarial reactions and anaphylactic reactions, we always stop the transfusion. We're going to administer an antihistamine, a corticosteroid, an epinephrine if we have difficulty breathing as well. For the anaphylactic reaction, you want to be prepared for intubation and respiratory support if that reaction becomes life-threatening, okay? Hemolytic reaction. Okay, hemolytic reaction is the worst possible reaction that can happen, okay? This means that we gave incompatible blood, okay? Hemolytic reactions look like chest pain, shortness of breath, fever, chills, hypotension, so they'll have a profound drop in their blood pressure, flank pain, They'll have blood oozing at the infusion site, nausea, tachycardia, okay? This is a very helpless situation a lot of times. You're going to watch the patient very carefully, especially during that first 15 minutes of any transfusion. If you see signs of this reaction occurring, we stop the transfusion immediately. You order IV fluids, oxygen, epinephrine, to help with the blood pressure because they're going to have profound hypotension, and you're going to observe the patient for any signs of coagulopathy. Okay, I've seen patients with a hemolytic reaction that their urine will turn black. Okay, we're going to work very, very quickly to stop this reaction. That's why in the initial period of that first 15 minutes, we tend to run the blood product a little bit slower. And then once we get through that 15 minutes and we have determined that the patient's not going to have a hemolytic reaction, then we can increase the rate. Hemolytic reaction is why we double and triple check the blood against the patient. We got to make sure it's the right patient for the right blood, okay? Hemolytic reaction, if they have a true hemolytic reaction, there's not much you can do to help them. All right. The last type of transfusion complication is something called circulatory overload. This happens either with a rapid infusion of the blood or excessive volume for transfusion. Your patients that are at higher risk for this are going to be your elderly patients, especially patients with a history of cardiac disease or renal failure. Okay, they're high risk for fluid overload. Signs and symptoms of this, they'll have chest tightness, dyspnea, tachypnea, hypertension because we have an overload issue, jugular vein distension. That's going to take about 2 to 6 hours after the transfusion. So for circulatory overload, you want to monitor their intake and output, their breath sounds, and their blood pressure. We'll administer diuretics as needed. And again, we're going to be high alert for which patients are going to be high risk for this. Okay. All right, that should conclude this chapter 27. Okay, make sure you guys look this over. Make sure you go over all these lectures in here, and that will take us to get us ready for chapter 28 with all the blood disorder, the blood disorders.